Thank you so much for joining us for our 7th webinar in regards to the epidemiology of the COVID-19 pandemic, sponsored by the Department of Epidemiology and Biostatistics at the University of Maryland School of Public Health. We're located in the suburbs of Washington, D.C., though many of us are operating from home. So welcome. For those of you who are interested in seeing the previous webinars, as well as the future tape of this particular webinar and the slides, you can access them on a website that I'm going to be posting in the chat box. So feel free to save that, and so you can go back and see the other resources that we're going to be sharing during this webinar. I'm very pleased today to be sharing the screen with a colleague of mine, Delight Satter, who I knew way back when she used to work at the University of California, Los Angeles. And then she joined an advisory group for the office that I used to work at, the Office of Minority Health and Health Disparities. And now she's working for the Centers for Disease Control and Prevention. She has a lot of experience at the national and the local levels in terms of addressing public health issues. So I'm very pleased to welcome her to talk about Indigenous perspectives of the COVID-19 pandemic. I don't want to take any more of her time, but I would ask if you could please mute yourself, and that way we can avoid background noise. And please hold your questions until the end, and that way we have an opportunity to really focus on what our speaker has to say. It looks like we're going to have a lot of opportunity for discussion, and we have a great group of participants. So I'm turning the screen over to you, Delight. Thank you so much.
Thank you. Olivia, can you hear me?
Yes, we can.
Great. Okay, so let me share my screen and welcome everyone. Thank you so much for joining us this evening. Well, it's evening for me. I really appreciate it. And I have to admit that I actually am just off of about a week and a half of vacation. And so it's, I'm integrating myself back into the work world from quite a wonderful de-stressing week and a half off. And what did I get the first second I opened? Oh, if you are not joining now and you're not on mute, could you please mute your phone, or not your phone? Well, it could be your phone. Yeah, great. That's great. Because we get a lot of feedback when you get a lot of calls like this. It's helpful to have everyone except the speaker on mute. So at 9:03 this morning, I got an email from my colleague who was going to share the presentation time, Kalinda from Australia. And she let me know she's ill. She just came back from working in the bush and she's not feeling well. And so she had to pass on today's presentation, but she gave me her slides. So I will be sharing a few of her slides and talking through just a few of them, but I won't do them justice whatsoever. So that said, we designed this together to kind of complement each other. So let's hope I can fill in the gaps. So thank you for joining us. My name is Delight Satter. I'm Umpqua and Klickitat from the Confederated Tribes of Grand Round in Oregon. I grew up in Washington State, and you all heard the introduction from Olivia. I was so pleased to receive an invitation from her. We have worked together on things like this for over 20 years, and the first time we met, we were actually at a summer symposium at the University of North Carolina, I think at their minority symposium. And Olivia was presenting on OMB 15, the guidance for the federal standards on race and ethnicity data collection. And I was filling in for Linda Burhan-Stipanoff, who couldn't be there. And I had, you know, all this excitement to be presenting with Olivia, who had done all this amazing internal work to improve race and ethnicity data collection for the Fed. And then there I was out there at UCLA and working with tribes and urban Indians on the same thing, but from a different angle. So we had a great discussion. Okay, so thank you all. I'd also like to give a land acknowledgement, which gets a little bit tricky when we're working virtually, but I am here in my little condo in Atlanta, and I'm on the traditional lands of the Muskogee Creek. And I am just very thankful to live here in their beautiful Piedmont forest. It's my privilege to be here and to honor this land. I'm out in the forest almost every day, getting my exercise and really enjoying living here. Okay, now I want to switch these slides to slides because I think I'm showing you guys the wrong thing. Here we go. Now let's hopefully I can remember all my notes. All right. Now, then I may need you to tell me how to get rid of me. Here we go. Let's make us tiny so we're not seeing that. Whoops. Now I do have I would wonder how we can get rid of this little box in the middle of the screen. If you're seeing that, I apologize. We decided to go with, now many of you may have joined thinking that we're going to give a big old presentation on Australia's Indigenous or the world's Indigenous population or the US Indigenous people and epidemiology and data, especially if you've read some of Kalinda and my work. But we decided not to go that way. We decided to use a learning theory and Indigenous ways of knowing theory. And if you'd like to learn even more knowledge, we want to refer you to this document as well as others that I'll share in Kalinda's slides. The Native American Cultural Wisdom Declaration by Chester Antone and others that you can find a resolution about on the National Congress of American Indians. So this is not a traditional lecture on epi and data and numbers. It's really focusing on Indigenous ways of knowing and how we can combine Indigenous ways of knowing and data for action and for public health. And it will probably not be very comfortable for some of you who expect somebody to come from CDC with a bunch of numbers and statistics and biostats. But frankly, you can get that in the MMWR, or you can get that from some of Kalinda's work in Australia. So we really wanted to go in this other direction, and we hope that you like it. And so a part of the story is, it might be hard to read in yellow, but it says, we age not by years, but by stories. So there's going to be some storytelling tonight. Uh-oh. My slides are not advancing, Bennett.
You would just need to click the right and left arrows on your keyboard.
I am, and it's not working.
Oh.
Okay, there we go. Good. Okay, so let's talk a little bit about outbreaks and infectious disease. So tribal communities, and when I say tribal for this portion of the presentation, I'm really referring to American Indians and Alaska Natives in the US, but I don't mean disrespect to Indigenous populations around the world, and I'm sure many of these points apply. So tribal communities have a heightened concern around infectious disease because of our historical experience with infectious disease. For example, smallpox, and the use of smallpox as a weapon, as a colonizing tool. But also, just like more recently, 1918, just 100 years ago, many Native people in the US and in the Americas and around the world suffered greatly from the smallpox outbreak. And in that case, we can actually recall stories. So for me, at my age, I can recall stories of the community and those who died. You know, when I was young, I was taught the number of people within my own lineage who died from that outbreak, and also the medicines that were used to help with remedies or with healing after the event. But also we were taught how the home, I'm from the Northwest, from the Pacific Northwest, and how homes would be built purposefully because we had such great knowledge of medicine. The style of the home would be built in a way that when people were ill with an infectious disease, there were temporary beds that were at the platforms of these openings, so that those individuals would have fresh air coming in and out. And so it would also protect those people who were inside the home, who happened to be living there when somebody was ill. So we have this historic experience with, the devastation of a world pandemic, but we also have historic knowledge and expertise in infectious disease and in caring for those who are ill. And of course, all at the same time, today, Native people have a higher burden of risk from many diseases, have, consequences, health consequences that are tangible. We really understand those from our health services research. And our health services researcher colleagues also do an excellent job at describing access to care barriers for American Indians and Alaska Natives. And it would have been so cool if Kalinda was here with us tonight, because one of the differences that we experience between here and in Australia is socialized medicine versus a place in which, here, where we have a very different and complex structured system. So regarding available resources for emergency response, tribes do have limited resources, and depending on which tribe you are in and where you are, there could be complex state and tribal relationships or local relationships. And complexity could be in a very positive direction or not. And so that's an added layer. And then the CDC has a funding mechanism called Public Health Emergency Preparedness. And it was not designed, and we could go into depth maybe in the Q&A if people have questions on policy. It was not designed to fund tribes. It was designed to fund state and local jurisdictions, and that's by statute. And there are there's some action taking place that might modify that, but they have not enjoyed the infrastructure building that other jurisdictions have had some access to, and locals also have had some limitations. So that's, in a nutshell, that is the backdrop. There's a lot of changes. COVID has brought about opportunities for new funding mechanisms, and we won't be getting into that a lot tonight because that's not the point of today's call, but COVID has brought us opportunities to learn more, grow, and improve, which is an important traditional value. Hopefully you guys aren't seeing this little 5 people are waiting to get in the waiting room or something at the top of the screen. Should I be clicking those, Olivia?
No, I'm admitting people as they come in.
Okay, I'm sorry. I don't know how to get rid of that on my screen. Okay, so let's go back a little bit more into traditional knowledge. So at the international level, the World Health Organization has provided this comment that Indigenous people of the world possess an immense knowledge of their environments based on centuries of living close to nature, living in and from the richness and variety of complex ecosystems. And so I think for public health, the grounding is that when the value in that local knowledge aligns very well with our public health principles of the best public health is local. That universities or federal agencies can certainly design toolkits and do great work on advancing science, theory, but that it's really always a community, whether tribal or other community, that refines and applies public health at the local level. And we know that that's the best from plenty of our studies and evaluation. And it's also important to recognize that traditional knowledge is key to Native people and others. And the World Health Organization recognizes that. So then how well we are implementing it in different places around the globe, that's the question, right? That's our challenge. And Native people have a cultural inheritance of survival and strength. And what you may be seeing a lot of in the press, well, what little press there is on Native issues or Indigenous issues, is usually a deficit model or some kind of a spin that's in a crisis and a problem, because that's the formula for media news or for earned media news. But I want to remind you all that Native people are here. We've been here for a long time. We will remain here, and we're survivors. And years ago, I was looking for a quote along these lines, and I found this beautiful one from Rita Ledesma, who's one of my colleagues in LA. She's a social worker. And she says that American Indians have a history of survival and strength, which is embedded within the cultural inheritance of the community and articulated through our culturally based values. And it's this touchstone for public health in data that I argue it beyond data, that the cultural inheritance provides protective functions that promote resilient capacities and serve as a primary resource for addressing social problems. Now, what does that really mean, right? Like outside of a social science jargon, especially for our friends who are epidemiologists or biostatisticians. It means like the construction of data, the use of data, the ownership of data, having data is foundational. Like understanding who we are is foundational to our cultural survival and to our sharing and to discovering solutions. So Native communities need data, but we need it for the usual purposes, but also because we really think of information as such an important value that can be applied and used in a native way to solve problems. But it's not even problems just for ourselves. We really want to be engaged in supporting other people in their health and their well-being. And so we want data. We're all about data. We're all about science, have been long time great scientists. So I like to share with people generally, and I know I'm speaking fast, but I want to leave time for questions and answers. The CDC and the Fed, we recognize the unique relationship between tribes and the United States. It's called the government-to-government relationship. And we do recognize and maintain our special commitment with tribes. And we try to improve on that day in and day out. And I work in the Office for Tribal Affairs and Strategic Alliances as the Senior Health Scientist, but I'm also the founding Associate Director for that office. And we've put in place policies and procedures to support our very specific mission. And we also look forward to improving that relationship over time. And one of the things that tribal leaders ask us to work on is data. So we're really thankful to our partners at UMD for making this opportunity to share. Okay, so around this part in the lecture, I like to switch to a little bit to make sure we all have a concept of what could be the problems with data, because I really know that's what Olivia wants me to get to based on our past work together. So these are just 6, I mean, they were off the top of my head, of basic problems that we have when it comes to data systems or data in the US for American Indians and Alaska Natives. And these may be very familiar to any of you who work with small population or dispersed population data. And so the first box is really key, like who is an Indian? And now, if we were in a smaller class size, I ask you all to vote on which ones you want to talk about, but instead I'm just going to rip through these. So who is an Indian is really important. And I want to point that out to you all, because don't trust anyone or anyone else's data or data sources on the construct of race. So American Indians, Alaska Natives are a racial and ethnic minority population, but we are also the only federally recognized political minority in the United States. And with that comes certain protections, but it also comes this need for data to be provided at that level for that demographic variable. Are you an enrolled member of a federally recognized tribe or a state recognized tribe? when you can get to that level of data, you really have the ability to look at information in a large database in a very robust way. It begins to describe and remove some of the confounding variables of access to care, for example. But it also is important because often subgroups of American Indians and Alaska Natives might have been top coded in a way you don't want if you are trying to do your own data analysis. So you may actually want to preserve or retain all American Indians and Alaska Natives into a certain subgroup and not have them distributed across other races for those who are multiple race. Or if you have somebody who is Latino and American Indian, you may want to preserve them in the American Indian Alaska Native category. So anyway, the main story is, work with somebody who really understands who is an Indian, what does that mean, and how the data is constructed in the resource that you are using so you can maximize that information. Now, the second box is a quote from my dear friend, Rick Brown, who has passed. He was our executive director at the Center for Health Policy Research, and he would always say to people, no data, no problem. And that's exactly what decision makers, elected decision makers, will tell you. They have to have data. Some will really push it so far as to say, you don't have a problem if you don't have data. Others will really say, I need data and I need the story, and I'm going to combine that to, have the best decision making moving forward. So no data is not an answer. We cannot have zero information on American Indians, Alaska Natives, and outbreaks or COVID or anything. Another key factor, which I'm sure we would get into a little bit in the discussion, is data sovereignty. And so when, who owns Native data? I work for the CDC now, and so the CDC, we're the recipient, we're a data user of data that is collected elsewhere. So that becomes complex. Data systems are not what people envision in their mind. They're not centralized under federal government, so that's complex. American Indians and Alaska Natives are members of their local state and their local county and city jurisdiction, as well as their tribe. The majority of American Indians and Alaska Natives do not live on or even near their reservation. 70% live off reservation, mostly in urban areas. And if you want to go even deeper, it's mostly on the West Coast in those large urban centers. So how is their data connected to their tribal community? Does their tribal community want that data? Do they use that data? So a lot of information around data use, data sovereignty is a contemporary issue, but it's been an issue for even longer than I've been involved. It's been an issue longer than Olivia has been involved. But these days with technology, we might actually have some solutions to some of these data problems. We have the usual, missing data, and the usual, which I've published a lot on, which is racial misclassification. That can be solved. And then, of course, we have not enough capacity and infrastructure around data. And we can work on this at the academic level by providing more tools. A lot of technology translation is needed out there for folks who can't make it to graduate school. And we have some newer partners in recent decades who can help on this as well. For example, tribal epidemiology centers. And of course, our usual public health schools have always been involved in supporting the infrastructure. Okay, so here's a few additional resources. This is for the hardcore out there. So the first one's not that hardcore. It's a collection of stories, and it's in AJPH book called Conducting Health Research with Native American Communities. I almost think it's a misnomer, even though some of my co-authors are on this call. I saw their names because it's not just research. There's some practice stories in there that if you're not a researcher, I think you still might enjoy hearing the lessons in this book. And we were really open. The authors not only shared successes, we shared where we might have failed and where we improved over time. Great stories in there. And this is a foundational book. It's being used now in many schools of public health as a textbook. But for the super hardcore who really just want all data all the time, whoops, this is the one for you right here. It's a study called Improving Data Capacity for American Indians and Alaska Native Populations. You can find it on the ASPE webpage. That's the Assistant Secretary for Policy and Planning and Evaluation at HHS. And this is a study conducted by the UCLA Center for Health Policy Research with a national expert panel. And Nanez Ponce was the principal investigator, and they examined 7 federal surveys for data capacity and how to improve, racial misclassification, tabulation, weighting, and reporting. I mean, the mega categories for the most intense data projects out there. And so I was just thrilled to be a part of that project. It just concluded in November and it went live, I think, in January or February. So any of you out there who are feds know how amazing it was to have a final product cleared through the federal government at that level in under 4 months. Just amazing. And we look forward to future opportunities to do some data trainings on that research. Okay. I promise you when we get to Kalinda's slides, you'll see a little bit more about some of the COVID info. So I will admit this person so I can see the title of my slide behind there. I think for Native public healthers right now is a super exciting time because we are receiving more press attention. Social media allows incredible information flow like never before. I can tell you when I started out in public health, when I would do a paper in graduate school, I'd do my little lit search, I would be lucky to scrape up 3 to 5 articles that included American Indian and whatever. And that was actually like before the internet. So, but now with gray literature in the available, social media, as well as like all these prolific and amazing articles being published in the scientific literature, we're actually at this point where it's overwhelming, right? And you might say to yourself, I'm seeing so much in the news, and how do I integrate and how do I deal with all of this information? And so I think it's a good place to be in right now, but I just want to be sure that everyone knows, like, it's not just social media that is your good news source for emergency preparedness. You want to have a complement of a variety of data sources. So I just show some examples here. Obviously the Fed, but then like here's Kaiser Family Foundation had some interesting news. And here's something that you could get off of the AP. Our colleagues at the Seattle Indian Health Board, they are advocates for access to data as well as other things. So they are always publishing new things. Seattle Indian Health Board has always been active in public health in amazing ways. But we have our wonderful colleagues. I know you can't see this, but this is a collection of evaluation papers that are Indigenous, valued, driven. And we're just in a place, and here I just saw this, young man was all about the census and Native American data and whatever he was doing. And I just think it's an incredible time. There's more data than ever before. And so get out there, really review your resources for data and be sure you're getting a good mix of authors and voices. And, obviously you can go straight to the community now because all tribes have their own web pages. Uh-oh, can't advance. Excuse me. Okay, so then we get to, I wanted to show you a few more things about moving off of the drama news that you might see in the media around COVID. So Olivia and I have a dear colleague, Michael Bird, who did a wonderful article around the need for structural change to ensure future American Indians nations, and that's in the Public Health Newswire. So some of the old traditional public healthers will remember when that paper would be mailed to you in your university office. You know, you can get it online now. And so that's a great place. But I wanted to show you a few examples from my own tribe. Hopefully you can see this, because it is true that I work at CDC and I am often on phone calls with communities around their COVID needs or emergencies, which I will not be discussing tonight because of the sovereignty issue and respect for tribes' right to really share those stories. That's not what I'm here to do tonight, but I can share you some of my own tribal stories. So I was really amazed in our tribal newsletter. First of all, we were amazed to protect the public. We had to close down our casino. And we are one of the largest institutions in Oregon and a huge tourist destination. We're close to Salem, between Salem and the ocean. And so we really enjoy a huge enterprise there. Excuse me. And I've had too many lectures today, so I'm coughing, sorry. So when we chose to close down the casino, we actually then shared the resources that were, you know, because a casino, of course, has a huge warehouse of foods and stuff that is stocked for the for the hotel and, you know, for all of the restaurants. And so they were able to share that with local food pantries. And here you see that we really had to switch gears, and we designed some home delivery for our elders related to the pandemic. And if you go onto social media and you join tribal web pages in your state or maybe in your region, or when you're just curious about, you'll see similar stories like this of ensuring that elders are cared for and community members are provided for. And these local, or what's called like ethnic media or local markets media, is a really nice way to complement what you might see at a national level, like, you know, Michael's presentation is for infrastructure on public health. And you can get quite if you're only looking at national news, you won't see some of the strengths about communities. And that's really what I wanted to get out while I was coughing here, is that amazing strengths, resiliency, and positive stories around COVID and solutions at the local level. This is a slide that shows additional resources. This is a wonderful podcast around traditional wisdom and ways out of UC Riverside with Juliet McMullen. These are just a few examples of what's going on now in social media. I'm going to cruise along, and then we'll segue into Kalinda's slides. This is a picture of my beautiful son, James. It's a couple years old, and we are at the casino. And this is my Chupi, my great-grandfather, Andy Riggs, who I would spend summers with as a little girl. He lived to be 106 years old, and he was a Tyee, or what you might translate to as a chief. And my family, we are like in a line of family members who were more like maybe diplomats or peacekeepers in modern thinking. And I wanted to sort of focus on relationships last longer than a lifetime. So that's the way when you are working with Native communities, you know, anything public health or anything at all, is that we're not even interacting really in this time and space, like right here and right now. we are working across time and across generations. And here's a story to tell you a little bit about that relational worldview that Native people have, and that, you know, we're thinking intergenerationally. So you'll often hear those people from the Iroquois Confederacy, they'll talk about the 7 generations approach to policy making. Other communities, well, they use the number 7 and 7 generations also, but they place themselves in the 4th generation. So you have to think back 3 and think forward 3. And then other people will be describing this to you, and they'll be doing back 4 and forward 3. It generally seems to be like about 7. I've worked with like maybe 150 tribes over in the US over time. And the key is, you know, it's not just about you, it's about you, your children, your grandchildren. And I absolutely know that my Chupi was making decisions for this little guy who he'd never even met. Okay, so I have provided a few links that will be shared with you later if you didn't already receive those, around very specific COVID resources, which, you know, Clinda and I decided not to get into in the presentation today. We really wanted to go more about the worldview and values. But of course, you can get more information all the time at cdc.gov COVID-19. You can also send questions, emails, and you can sign up for the weekly newsletter out of our office, the Office for Tribal Affairs and Strategic Alliances, just by emailing that email right there. If you are really interested in emergency response, and I've received a lot of calls from individuals in public health who are interested in learning more, or people who don't have a public health background but find themselves in a tribal setting where suddenly now you are now doing emergency response. I do strongly recommend the online FEMA trainings. They're free, they're easy, you can do them, you know, from your own laptop. Once you gain the language of emergency response for public health, it really helps understand how to navigate resources and ensure that you're staying up to date on information. Here's a few of our partners, and there's many more. This is just a sampling. Any resources you're looking for, feel free to contact CDC at any time, and we'll help you navigate. That's one of our strengths. There's how to get us. There's our team at CDC. And I'm going to switch to Calinda's slides, unless you were going to set those up, Bennett.
No, so you would have to share your screen again once you're on her slides.
Okay, why aren't they there? I thought I already, okay, here, she turned hers into a PDF. We're set. Let me check the time. Oh, I better go faster, which is easy because I can't do these justice anyway. So let me share with you, let me try to figure out how to make this bigger for you all. I hope that's better. Calinda again, for those of you who are joining a little bit late, my dear colleague Calinda Griffiths, who is going to share the presentation with me and do a little bit more of the international story and story from Australia about Aboriginal and Torres Strait Islander people, is unable to join us tonight. She regrets that, but she's happy to receive questions and comments from anyone, and you can send those in to Olivia, and then we'll coordinate, you know, with Calinda and get responses for you all. Calinda and I are both members of the National Center for Health Statistics group called the International Group on Indigenous, what are we, IGIHM, Health Measurement. And that's where I met Calinda, and we've really enjoyed working together and advocating for data. And she works for the Center for Big Data Research and Health. And she is an extremely gifted speaker, and I really wish she could be with us. But I also enjoy the fun in her slides. Look at her candy hearts. And I'm not going to get into this because I don't know this place, but she lives here in Darwin. And here you'll see at the bottom, if I disappear if I can make that go away, well, you would be able to see the percentage of the population. Looks like it's about 3% of the total population. There we go, 800,000. So, you know, for the US, depending on.
Delighted, I just wanted to let you know we're seeing your old slide set. We're not seeing the new slide set yet.
Oh, good. Okay, thanks for letting me know. You don't want that other one.
Yeah.
Okay.
Sorry to interrupt.
No, thank you for, you know, remember you guys are supposed to do that. You just have to tell me what I'm doing wrong. Let me stop sharing that. Wait, can you stop sharing for me again like you did before? Okay, good. Thank you. And then I will share the correct one. I forgot that I only shared the app I was on. I didn't share my whole desktop with you. Okay, yeah, you want to see these cool slides of hers. You don't want to just, I was probably on some placeholder slide on my set. That would really be boring. Okay, here are Kalinda's slides. Here's her cute data. She loves data. Okay, better. Here is where she lives. And the population overall, small, but numerically, you know, big. It looks like about 800,000. For those not familiar with the US, depending on who's counting and how you count, there's over 4 million American Indians in the US today. Here's what we were going to discuss together. Some of these issues you'll see are similar to those boxes that I had laid out. So her part of this presentation was going to complement that. Who is counted? How many people are counted? What is measured? All things that I'm sure those of you who are students of Olivia's have studied in depth. Those are the key questions. She talks about how definitions of Indigenous have changed over time. That has also happened in the US, and one of the biggest changes, of course, has been that in the US, tribes now determine who is a member of its citizenry. And previously that was determined by the Fed. So you can begin to see over time how federal policies caused distrust of federal systems, and how my job is full of trying to rebuild trust with people and improving structurally the systems to you know, really do the best and provide best information for public health decision making. She was going to talk a bit about human rights, and Australia seems to really be undergoing this a new approach and a new day in regionalization and data collection, and really valuing Aboriginal and Torres Strait Islander people in the inclusion of that process. I would have loved to hear more from her on that. But they have similar issues to us: data collection issues, data itself issues, measurement. Same things I was talking about earlier briefly, the tabulation, weighting, and then how do you report the information safely once you have conducted your analyses. Quality and data coverage. Here she's provided, what she provided was a success story on COVID-19. And we did talk about this, but it's been a few weeks, so I don't want to discuss it and not be able to recall the details. But in a nutshell, it was that through engagement and local level control, early identification of the problem, and rapid emergency response, that they were able to prevent illness. This slide talks more about the regional model for the care design system that I can't speak fluently to. But just keeping in mind that their health system is different than ours, as is other places internationally, and so the US is quite unique. But she's provided a reference down here. If you're interested, go grab that article. I do like that slide. It's pretty cool compared to mine. Another reference that she's provided. Several of these colleagues are on our IGIHM group. And now that I'm seeing this, I'm also remembering I'm going to have to switch back to the notes page because another colleague shared a reference for us to share with you all out of New Zealand. Kalinda does a lot of work at the international level and the UN, so she was going to talk to us about Indigenous people having the right to determine their own identity or membership in accordance to their customs and traditions, and this is recognized at the UN level. And this Indigenous people have the right to dignity and diversity of their cultures, traditions, histories, and aspirations, which shall be appropriately reflected in education and public information. That's a really important grounding principle, and it's related to the cultural wisdom principles that I was sharing earlier from the international community. Okay. Just giving you a few minutes to kind of breeze through her slides. Okay, let's look at this one a minute. So considerations in conceptualizing data and Aboriginal and Torres Strait Islander people. So their model appears to have a little bit of a different approach to the way we organize information or our frameworks in the US. So they have operations, monitoring, priorities, and recognition. So right away, if you are used to working with native data in the US, you see like this is kind of a different element or a different way to think about data and Indigenous peoples. Operations, yeah, we're pretty good at that. You know, we need more resources to do that, but implementation and training and procedurally, in fact, you know, our friends from around the country do come to us for some of these. So we're doing okay there. Monitoring, we definitely need more improvement around the areas of policy and data and the procedures for that and progress. Maybe we would put evaluation. In the US, we probably call this policy evaluation and other forms of evaluation. But it's always nice to look at those international models and see where we can, you know, come up with some different ways of thinking. And then they have priorities. We are working on priority agenda setting in the US. And I think they're a bit ahead of us. They're on priorities around research, the role of community, the role of individuals and governments. I like that approach. And they are formally recognizing the UN DRIP, the United Nations Declaration on the Rights of Indigenous People. If you are a researcher out there and are not familiar with that, that's one to look at, as well as several tribes have the conduct guidelines and policies for the conduct of research. And if you measure up your activities, either public health practice activities or research activities against these models, see where you might be interested in improving or changing. That's a good idea. Okay, so that was the end of her slides. And we now have about 10 minutes for Q&A.
Great. Thank you so much, Delai, for your presentation and for covering the slides. Also sorry that Kalinda is ill, and I hope she recovers quickly and is able to answer questions that anybody has. As a reminder to everyone, we have put links to the posting for both sets of slides up on a Google Doc, and I've included that in the chat box, so feel free to click on that and then you can save it for later, as well as links to additional resources that you had shared. I also added a link to the revisions of the Federal Standards for Racial Ethnic Data, since you mentioned it at the very beginning. As you know, there was a question that was sent to us beforehand, and they wanted to know, they said, thank you for the opportunity to submit questions. I have a concern about holding sweat lodges. There are many opinions about how sweat lodge ceremony either kills the virus or provides it a place to flourish. Can you provide scientific data or information regarding sweat lodges and the virus? Can you provide any information on what transmission of the virus within the sweat lodge would actually look like? Any suggestions for sweating in closed populations like prisons or within family or close communities? This was a question from Winona Stevens from the Native American Reentry Services in Tacoma, Washington. And if you don't have the answer, perhaps, Delight, you can give us some suggestions as where to track down information about this question.
Right, exactly. So what I would recommend, so I don't have the answer to that, but this is the kind of question that CDC can whoa, says my internet is unstable. Can you hear me? Hello?
Yes, we can hear you.
Thank you. Thank you. Do you see this tribal support at cdc.gov? If you send an email there, or if you go on to the cdc.gov COVID-19, you'll see where you can click to send in a question. This is the kind of question that CDC would receive. And because I don't have working information on that specific topic right now, I can't answer that question, but we're happy to get back with that person. But it's really great to hear that kind of a public health question, because it's about health promotion for those who are on the call who are not Native or not familiar with sweat. It's both a physical and a spiritual practice that many tribal communities and urban Indians participate in. And basically you heat up your body and you're in a small enclosed place. So, you know, concerns around infectious disease are always key. And we have always enjoyed, public healthers have always enjoyed great partnership with traditional medicine people and people who lead ceremonies, whether it's Sundance or sweats, in protecting the health of those people who join them. And I really love that question because it talks about the blending of traditional knowledge with the latest, you know, scientific information on protecting our health. So we'll get back to you, but I will need you to email in to that, to the email page, and then we'll route it through the system and we'll get a response.
Delight, we were unable to see the address. If you could repeat it, I'll put it in the chat box.
Okay, just email tribalsupport@cdc.gov. Or anytime, not just for this outbreak, but if you had, it's an emergency response this level, if you just go to cdc.gov, you'll see like whatever it is, Zika, you know, click here, and you would click on it, and then you'll get into a link that allows you to email into whatever the response is, Ebola, Zika, COVID, wherever we're at. But you can also just do the tribal support at cdc.gov, and we'll route it into the Emergency Operations Center for on your behalf.
Great, and actually it looks like Stacy put the tribal support unit, the COVID-19 tribal support unit email address in the chat box, so thank you.
Oh, great, thank you so much.
Let's see, I think somebody was asking about questions about Australia, but I think we're going to have to refer them to Kalinda. Jim Gaudino had a question early on. Jim, do you want to ask your question verbally?
We know Jim.
Yes, we do.
Copies of my slides? Yeah.
You don't know that. We shared the slides, but I think you had another question, Jim. Hey, Jim.
Hey, how's it going? Yeah, what was my question? I think I was talking about the, and I have to kind of say this about myself. I used to work for CDC and was one of the first CDC persons assigned to one of the tribal epicenters here in the Portland area. And what struck me most as an epidemiologist was kind of the total disconnect between the data sources that state and local health departments and CDC is using, and the lack of such sources that was available, for the tribal epicenters. And I think, one example that came to mind was YRBS and the lack of information about Native adolescents around important issues such as suicide ideation. So the question is really about the kind of disconnect of data and in availability and sharing, not just between the tribes, but also between state and local health, tribes, and also kind of lack of coordination here in the U.S. I don't see a lot of coordination. You're at CDC, and you probably see a lot more. So Delight, please kind of bring us up to speed. Thank you so much. I really appreciate the all you've done and your presentation today. Thank you.
Okay, people will think he's just a plant in the audience. So there, especially for our international people who've joined internationally, we better describe that it is disjointed. Like, data is collected at a local level. Surveillance, there might be some surveillance projects that are done by universities or health departments where there's some different information, but like the Youth Risk Behavior Survey, that's a state-based survey. CDC has for 20 years allowed an employee to provide technical assistance to tribes who want to deploy their own youth risk behavior surveillance data collection effort. She's wonderful, Sherry Everett Jones. But let's just use that as the example, Jim. Sherry came to me, I think last year, and she said, Delight, I really wanted, I have some time. I'd like to do a special project with the Native population. What kind of project should we do in data? Because I actually worked with Sherry back in the 90s when I was a fellow at CDC, and we did, the CDC does conduct a special YRBS for Bureau of Indian Education schools. So I'd done that analysis with her, and that's not publicly available. The BIE schools do not want that out. And so, I said, well, why don't we just bring you up to speed on racial and ethnic classification? And she says, what are you talking about? And so I introduced her to the complex world that Olivia and I love of, maximizing data sources and really re-crunching the numbers with different constructs to see what we could squeeze out of YRBS data, combining years and doing some, hotshot stats. And we were thrilled. We actually got large enough sample to improve the quality of information on suicide ideation, and I think alcohol use, I can't remember the detail. So more robust information and more precise estimates. And that, we're waiting for the next year's data to rerun it and come out with the latest. So I think it's taking time to create the network, the relationships. It took me time, right? When you first met me, you were probably in EIS or something, and I was PHPS. And so then I went off to UCLA and, studied with Rick Brown and Steve Wallace, Jerry Kaminsky. I learned from them. But we also launched the California Health Interview Survey out of the center, which is the largest health survey in the US, conducted in 7 languages. And so I learned a lot through that whole process in how to maximize data, ensure data decision makers are included in the collection and design of data, creating, data tools for decision makers, data into action, community coalitions, all that stuff that you can like data people, data wonks, data jockeys, they don't have to be stuck just doing epi and numbers all the time. They can expand and do these new and cool things. But it's taken a while for these new and cool things to move into the different areas across CDC or across states, and to share that information. Like I mentioned, the ASPE study, that is amazing. It's incredibly complex, and you really need that caliber of scientists to be working together. And it took us years to build. And people used to say to Rick, you know, hey, how long did it take you to, you're so successful. How long did it take you to get the California Health Interview Survey going? And he said, well, I started as a graduate student at Berkeley in the 60s. And it took us, I think it took well over a decade to build the coalition and the movement to really get data where it needed to be, and the funders, you know, the alignment of funders and resources and all that. So what I'm seeing is all this activity. And the other thing I would say, Jim, she's like, you can tell it's late, and this is a Native woman who's getting older, because the older I get, the longer I talk to answer a question. But, you know, the other thing is, when I was starting out in public health, tribal leaders were not talking about data. I mean, we would have to, you know, talk till we're blue in the face, really, to get, you know, tribal leaders to be down with data. And that has really changed. You really see the value and the utility, the advocacy for data out of tribal leaders, not just out of the public health folks who work with data. So that has changed the discussion as well. Maybe the information age has also helped with people outside of your world really being interested in data. So I think right now, you know, we're in it, and we've got these young people who are graduating and who love data. People are not afraid of data anymore. It's not, you know, you're not just limited to those people getting the epidemiology degree who are data users. You have all different kinds of data users. Of course, we still need our biostatisticians to help us do the incredible work that they can do, and our epidemiologists. But I don't know, I'm very hopeful about where we're going with data and making it applied and useful at the local level.
Delight, thank you so much. We are right at 7:03, so we've actually gone over a little bit, but I wanted you, if you could share some words of wisdom. We have many students on. You got a Master of Public Health degree, and certainly can speak to what are you drawing upon right now? There's so much negative news out there. You took some time off. What little tidbits of wisdom would you like to leave our students and the rest of the call as to how to keep ourselves sane when there's so many things that are going on that can be rather overwhelming?
Right. Okay. So the first and most important thing is stop watching the news. So, you know, I remember learning this after 9/11. So I really felt pretty oversaturated, you know, like with that happening in the news. And then I was so fortunate. Now I probably am not even sharing a screen, but I should share the one I want to share. This man, hopefully he's in these slides for you. Did I keep his picture in here? Yeah. Okay, here. So this guy right here, that's Tony Stately. So Tony Stately says to me, you know, and he sent out an email to the Los Angeles American Indian urban community. He's a clinician, a community psychologist, you know, turn off the news, that there's this thing called oversaturation, and it becomes overwhelming, and it really makes you feel incapacitated. And that if you had children, you really needed to turn that off, because he was a child psychologist. And it was really helpful. And he gave other tips and tools. And you can go to like the American Medical Association or the American Academy of Pediatrics if you're a parent, and get some information on how to keep up to date on what's going on, but not to be overwhelmed. As you could see, Olivia, from my presentation, I very purposefully tonight, even though I could have, I'll show you guys my little, what I said I was going to say, I didn't say because I forgot what I was saying. Kalinda and I both decided purposefully not to do that to you guys tonight. We purposefully were not going to overwhelm you with data. Although, you know, it was my privilege to be an employee at CDC and write the fact sheet at the request of tribal leaders on funeral practices and safe funeral practices. That was a grueling day. I'm telling you, it was a 15-hour day synthesizing all of that science into a culturally appropriate draft for a team to review and do. But I didn't want to do that to you all tonight. I wanted to be sure there was more of a balance. And when you read the news, you have to read the news, but you have to take it in balance with the things within your control and what can you choose to do. And one of the most important things for you to choose right now is your own health and well-being and the health of your own family. Like those have got to be priorities, right? And that can be really difficult to do. So I've of course received requests to deploy to Indian country in the response, and I can't because, you know, I'm a little bit older and I'm a little bit at high risk, but also because of my own family needs. And that can also make one feel guilty, like, and you all might be feeling like, you know, what you're doing might not be really what's the greatest need right now or the highest priority. It's not true. Like being a student, being a community member, caring for others, caring for yourself, those are really important. And these ladies right here would be the first to tell you that. You know, Auntie Betty and Elaine would tell you that's important, and that, you know, the world may be out of balance right now because there is a pandemic or there's this rampant infectious disease, but we survive, right? Native people have survived this. We will survive this. The world will go back into balance, and to focus on health promotion. I think the other thing about the news is because of the formulaic way that they tell stories, they don't sell if they're telling stories that are sort of the classic success stories in public health. And keep that in mind. That's why I really emphasized over here for you all how to find other news. Like, wait, well, that's a good one, but like this one, right? Get some local news, get some ethnic media, get some stories from public health elders. Of course, reach out to your school-based counselors if you're feeling overwhelmed and it's too much. They can help guide you through these times as well. And then I also think it must be hard to be a student these days and think, what's going to happen in the fall? How am I supposed to learn as much as I should be learning if I'm, you know, learning from distance education? And you can do it because look how brilliant tribal people are, and you know, for so long, like totally removed for, I can't even get you guys back on the, I'm looking for your pictures. There you are. Okay. We can do things at a distance. Like I said, I've worked with over 150 tribes over the years, right? And hey, we weren't together. We were doing things virtually, and we were doing things by phone or even mail. It can be done. So, you know, keep in contact, build a relationship with the communities in which you work with, stay in touch. They care about you, you care about them. Build that relationship over time, over generations, and just think towards the future. Reach out to your friends and family when you have need. And if you're really feeling distressed, or you think, hey, am I really distressed? Is this too far past like what I can tolerate? That's when you reach out to your school counselors and your programs. And if you don't know how to find those, your student services can help you, or any of your professors can help you navigate to those resources as well. I hope that did it. Olivia, I think you should have the final word on how do you deal with like the struggle of data. We need data for public health and we don't have what we need. What do we do?
Thank you so much, Delight. I think we could continue for well over another hour, but we promised them it was only an hour. So I think we're going to have to stop right now. Thank you for your words of wisdom. All of you, we've included in the chat box a link to a Google document that has links to the slide presentations. And we promise that the video presentation is going to be available later this week once they do some slight editing. And thank you. And we hope to continue this series. We'll let you know when the next ones come up. Delight, you were so generous with your time. Welcome back. I'm glad you had a wonderful, restful week.
Thank you so much. And thank you for all your extraordinary years of service to the federal government. And the students are so lucky to have you now.
Thank you, everyone. Please stay well.